Right, everybody, welcome to episode nine, if I can get them all in there, of Coffee, Compliance, and Chuckleheads. After a 2 week hiatus, Eric, Jordan, and myself, we are back. We are ready to roll. We are excited to be here today and anxious to bring you, I think, just a tremendous amount of information tied to all things healthcare. I want to say to my good buddy Jordan, welcome back. Our buddy got struck down with the COVID virus and was out for a few days. But, as they say, you can't keep a good man down. So we're glad to have you back. And thank God you and Emily are both doing well. And it doesn't seem like there's any residual long-term effects at this point right now beyond those that we already know that you had.
There'll always be a defect.
And then Eric, welcome back. I know you were out in Las Vegas at HIMSS. Jordan, I know you were there as well. I'm guessing you guys had a great time at that conference. One of these days I'll get invited to HIMSS and I'll get a chance to join you guys out there.
Well, it was weird. We were all walking around in OSHA A-rated protected gear. I mean, it was like, you had to walk around like you were transporting nuclear material, so you needed proper protection to be around there. So the conference was interesting in the sense that they really did make it a very safe environment. You had to be vaccinated to go. You had to have proof of vaccination to go to get into any of the events. There was a lot of safety involved with that. Masks were worn the entire time. Obviously, if you're in an event, you're taking off your mask some of the parties and after events and stuff. But Las Vegas has a mandate of masks out in public spaces. They reinstituted that a few weeks ago. So you have to wear the mask when you're walking inside of any of the buildings and up until the time you sit down in a restaurant to eat. But HIMSS, which was a much scaled down version, for those that know it, it's usually attended by some 50 or 60,000 or more people. This one was a much scaled down version. And you wore the mask and you just sort of dealt with it. I mean, we're all
nothing like wearing that mask in a smooth 110 degrees.
I was just around the corner from you guys. Jill and I were up in Reno, and same thing. Obviously, state of Nevada, mask mandates were in place. You could not get anywhere in the casino without having a mask on. If you did, somebody was coming up to you nicely and saying mask. So yeah, I mean, look, we're right in the thick of the Delta variant. I'm sure we're going to hear about another variant that comes up, but you raised a really interesting point, Eric, about proof of your vaccination. Yesterday, on the Compliance Guy Live with Amanda Wesh, we talked about the misinformation about the fact that, a COVID vaccine card is not considered protected health information. And if an employer requests it, if a conference or an airline requests it, they are not violating the Health Insurance Portability and Accountability Act. This is something that they have the right to request. And again, the reason why this isn't anything protected under HIPAA. Right. So I think there's a lot of misinformation. Real quick, I want to thank OncoSpark, Doctors Management, Advise Health. I want to thank Invader Coffee. I've got my cup of coffee, my cup of Joe ready to go here today. I got my whiskey bourbon barrel blend. I just feel like that's what I need for this show. So we're good. I also want to thank the National Alliance of Medical Auditing Specialists, the Chuckleheads. We are going to be at the NAMUS 13th annual conference that's coming up starting on December 6th through the 8th in Clearwater Beach, Florida at the Wyndham Grand Hotel. We will be broadcasting live from there on one of the days. We will have one of our shows going on. But if you all have not taken a look at the NAMUS 13th annual conference, you don't want to miss it. We have incredible speakers that are going to be there. Amanda Wesh, Matt Lahan, Eric Rubenstein, Jordan Johnson, Robert Lyles, yours truly, and a whole host of other incredible speakers. Paul Spencer, Stephanie Howard, Scott Kraft, Grant Huang. The list goes on and on and on. This is an all auditing, all compliance conference, and definitely one you guys don't want to miss. But one of the things that I thought that we could do as sort of a quick down and dirty news segment, if you will, and then it gives us a chance to talk about some of these things. I want to kind of do a noteworthy breaking news, if you will. There's a lot of different podcasts. There's some different streams that are going on out there. There's Matt Weitzel, who I have a tremendous amount of respect for. He's with the American Health Law Association. He does his podcast, but I think, we have just this different roundtable of the three of us with this level of consistency where we're hitting on areas that we have our backgrounds in for the last, combined 60 years between us. And of course, the majority of those those are Eric's because he's the oldest of the group. But what I wanted to do is quickly talk about the fact that, I have a lot of doctors that reach out to me. I had one that reached out to me while I was on vacation with Jill. We were in Reno and then we went to San Diego for another 5 days. And this doctor called me and he said, "Hey, Sean, listen, I had this this distributor come into my practice last week." And he said, "Doc, I have something that's going to revolutionize your practice. It's going to make you a tremendous amount of money. It's approved by Medicare. Here's some examples of claims that they're getting paid, like $2,800. Now, you guys are going to laugh because we've talked about this." He said it's amniotic fluid. And he's in New Jersey. So, Eric, I know you're in New Jersey right now. Pain management doctor. Folks, again, amniotic fluid is not approved for musculoskeletal use, okay? It has limited approval. But what was really funny was, the doctor was like, "But Sean," and I said, "Listen to me, I understand." He showed you these official documents. One of them said they have an approved Q code, okay? A HCPCS code is not an indication of coverage. This is approved by a subcommittee of the Centers for Medicare and Medicaid Services. This is not an indication of coverage. If there's no NCD, no MCD, no LCD, no LCA, there is no coverage of the service. Fair enough, Eric? As a former investigator, if somebody was billing for something and there was no coverage guideline, isn't it fair to say that there is no coverage of that service?
Yeah, I mean, oftentimes when we were working on cases, the very first thing you'd have to do is you'd have to go and say, okay, look, everything that this provider is doing appears to be a violation of law. There's a fraud. There's something there. But then you go and you find that there's some regulatory guidance that allows it to occur. So one of the things that an AUSA would always say is, what's the coverage on this? What's out there that says you can do it? Now, there is one caveat that I'll provide, and that is with off-label marketing as it pertains to clinical documentation in the compendia. So under Part D, there are instances when the off-label use of a drug will pass muster when there's clinical indications of it that would support that. And that's tied really to some of the off-label issues that sales and marketing reps in the pharmaceutical industry may have with prescribing providers with respect to off-label. There's actually a Second Circuit decision involving a pharmaceutical company that alleged a freedom of speech issue under the First Amendment and the compendia. But generally speaking, that's right. If there's no documented coverage determination by CMS, the fact that there is a code available does not inherently mean that it's going to be paid. And it's really a twofold. One, is there a code? Yes. It's really two, and then a 2A. It's one, is there a code? And then really the other piece of that is, if there isn't a code and they're using those catch-all 99999, is the documentation really supportive of the fact that there isn't another code that is applicable for that? And then two is there a national coverage determination? Is there a local coverage determination? Is there some regulatory guidance? So, in the absence of those, people that are getting involved in that are really at their own peril. Parallel to that really is the issue that really is the more important piece, Sean, which is when you've got the reps from these companies coming in and providing some sort of documentation that is indicia of billing and coding advice. I know I've had cases that involved providers who were relying upon billing and coding advice, and that may help you get out of some of the criminal intent issues on a fraud versus a waste and abuse matter. But relying upon the guidance of a company who has an intrinsic interest or a fiduciary interest in getting that item, product, or service to market through the doctor being able to buy that item is really where that problem becomes.
Yeah.
No, we see that on our side is a lot of times they kill me. We have a white paper. And so what these companies do is they'll go find a consultant to write them a white paper and say, well, this consultant on the billing and coding says, and so then it's like you said, it's like diffusion and delegation of responsibility. And I mean, as soon as people will see a white paper, hopefully we get that call and be like, dude, they have a white paper. So this white paper means we can bill it. I'm like, that white paper is worth about as much as the paper it's written on.
Exactly.
I mean, anything, but that's very frustrating. To Eric's point is people hang on that. And as soon as they see it, they think it's like their golden ticket to go.
Yeah, no, you're spot on. You're spot on. But look, I want to take it a step further. I want to talk about some of the stuff because, again, we are still right in the thick of COVID-19. For anybody that has contracted COVID-19 over the last week, the last month, or whatever it is, obviously, we hope that you guys are all right. We pray for everybody out there in our country and for those around the world that are affected by this miserable virus. We got word while we were on vacation, my wife and I, that our two youngest grandchildren, who are 4 and 2, both got hit with COVID-19. They had double ear infections and double eye infections. So, as a papa, you never want to hear, that your babies aren't doing good. But, thank God, because they don't have any underlying systemic illnesses or any other problems. They're kids. They're resilient. They've been able to bounce back from it, and they're on their road. But I want to talk about these noteworthy news issues and tie them directly to COVID, because I think some of them you and I, and Jordan, we're going to laugh about a few of these. And I think this is one of the reasons why people want to tune into the show, because there are some bonehead things going on, but there are also some things going on that you and your practices may think you're okay. You're doing it all right because you got coding advice from a consultant, to Jordan's point, or you reviewed a white paper, or you were on a listserv from one of, the credentialing organizations, and, somebody who you thought was a trusted resource, put out some information and you didn't verify it. You didn't independently, review it to make sure that it was accurate. So let's talk about a few of these things. Eric, I think you posted something about this one. This was on August 17th of 2021. A pharmacist was arrested for selling COVID vaccine cards online.
Yeah, this one was amazing to me because so the pharmacist was pilfering the cards. They didn't name in the press release what pharmacy chain he worked for. They just said it was a national pharmacy chain, so it's probably one of the big box. You go in there now, it's walk in, you can get the COVID vaccination there. I went into a big box to get mine. And this guy was pilfering the real cards. They weren't the fraudulent cards that are being manufactured. And he was selling them online for $10 a piece and had sold 125 of them. So that, my non-accountant math, that's $1,250. So he essentially sold his soul for $1,250. Now he's obviously facing, I think they charge him with 10 or 11 counts under federal statute. Obviously, he's risking a long prison sentence for something like this. Should he be convicted and they really take the action against them? Obviously, there's some state licensure matters that may come about, from the pharmacy board. Mandatory exclusion, minimum 5 years under OIG's exclusion mandatory guidelines. And obviously, as you all know, there are aggravating factors that may increase it. And this I could see, in a public health crisis, that they're going to say that there are aggravating factors because, the people are getting these cards. So this guy essentially sold his soul for $1,250. And, it makes you think from a Chucklehead perspective, if you're going to do something, it better be for a number that has like a B at the end of it, and you can just disappear. But for $1,000, and I joke and I said, I mean, that's barely gas money these days on a big SUV for a couple of months.
Yeah.
I mean, it just fits like that. If there's the Chucklehead Award of the week, it's this guy now, granted, he probably had stacks of these and was intending to do it for, more, but at $10 a piece, you got to be kidding me that, this guy's gonna lose everything that he knows over $1,000. I mean, if you're gonna do it, disappear, bro, disappear.
Yeah, have enough money to buy an island somewhere in the South Pacific,
Yeah, I mean, that's a bargain, right? I mean, you get him for the price of one. I mean,
that's it.
And then we had, let's see, Mississippi. We had in news, keeping with this, a pharmacist plead guilty to more than $180 million of healthcare fraud for a compounding fraud. Actually, right down the road from me. I'm in Mississippi, so it's actually not too far from me where this occurred. But he was adjusting the percentages of the medications without regard to or any of the efficacy and stuff like that, and then soliciting recruiters to go and procure sales of this to fraud TRICARE. So I'm thinking guys, I mean, it had a lot of ingredients, right? So some of the ingredients pay different. So he didn't care anything about the end outcome. It's like, how can I dial up what I'm going to get paid the most for? And then boom, send it out there to the masses.
Yeah. Well, those cases, I teach this semester, I teach at the University of New Haven. I teach in a graduate program there, and I'm doing a class in October. It starts on pharmacy fraud. And I talk a lot about in my course, the compounding fraud and how what's known as the NCPDP changed the manner in which claims get submitted by pharmacies to the PBMs, and they use something, without getting into the weeds, called the D.0, and that has to do with listing the ingredients. And I am of the belief that when NCPDP changed that rule prior to 2012, the rule was that you only listed the most expensive ingredient and you got paid for the single ingredient. In 2012, they said we have to list all the ingredients. Well, as a result of that, now the reimbursements went through the roof, and the compounding fraud became, pretty pervasive as a result of that. So, yeah, I mean, these, the Chucklehead factor. I worked on 2 or 3 compounding fraud cases at the OIG, and what I'll say is, and we've talked about this many times, is that it's not telemedicine fraud; it's telemarketing fraud. I just posted on LinkedIn this morning about a guy. They out in Michigan, they were calling it Happy Clickers is the operation. And, I talked on LinkedIn this morning. I posted about a case that I worked right before I retired, where the joke that we had internally was that we wondered if the doc was going to file a workman's comp claim for carpal tunnel, because he was clicking 50, 60 prescriptions an hour. And it got so bad, he couldn't, before he got a digital signature, he was having to print them up and actually sign them and then scan them, but his printer couldn't handle it. So he was he'd get the prescriptions to his Yahoo account, which is a whole other problem, right? So he gets the prescriptions on his Yahoo account. So there's a HIPAA violation there. And then he's forwarding them from his Yahoo account to a general inbox at a big box store, office supply store, where they're printing them for him and putting them in an envelope. And then he shows up at the end of the day with a pen, and he just sits there and signs them, and then they email him back. And what's funny is, during the investigation, my partner from DCIS, Department of Defense IG, we go to the big box store because we saw from his emails where they were going, and we showed a picture at the desk where they do this, and the person goes, "Oh yeah, that's the doc. He comes in here almost every day." They knew him. You're talking about a big box office supply store.
Unreal.
They knew him because oh yeah, he comes almost every day. We print up 50, 60 pieces of paper. He signs them in about 2 minutes, and then we scan them back. So it's, it's not really telemedicine, it's telemarketing. And,
yeah.
You got to start switching the name.
Yeah. And I want to stick with that, right? Because in other newsworthy notes, okay, telemedicine company, okay, this was just on Tuesday, August 10th. Telemedicine company owner charged in superseding indictment for $784 million healthcare fraud, illegal kickback, and tax evasion. So this Chucklehead, okay? So once again, this one is in Highland Beach, Florida, And this chucklehead, once again, is tied to durable medical equipment in Florida. And I bring this one up because, Eric, you and I had a conversation yesterday because I asked you to reach out to the SAC at OIG in Miami because and before I even talk about what this chucklehead, it doesn't even matter what this guy did. He's just not very intelligent. Here's my biggest problem that I have, and I said this right before we got on to the live stream. The government's got to do something because the readily available access to providers' NPI numbers and to their PTANs, to the enumeration date for when their number was granted, the update of that number, everything that you would need for a chow, right? If you were this really dirty, low-down scoundrel who was looking to bill Medicare or other payers, utilizing the information of an unsuspecting physician or nurse practitioner or PA, excuse me, everything you need is on freaking Google, okay?
Yep. Click away.
Yeah. I mean, yesterday, so I get, we already had at one of my clients, we had the Office of Inspector General show up, and this was in Florida, because these DME companies got hold of multiple orthopedists' NPI numbers, their billing addresses, all of their information that they need, right? Because if you just do an NPI search for Eric Rubenstein, MD, you're going to get like 5-6 different hits, and it's going to pull up every single piece of information about Eric Rubenstein, MD, right? So OIG came in and, they question our physicians, they question our staff. We're like, whoa, what are you even talking about? Folks, this is why you have to continuously be monitoring your claims. You have to be monitoring what's going on the dark web. We could post after today some things where you can actually go on the dark web to see what information of yours is available. I think there's going to be a lot of people that go out there, and not just doctors. I mean, look what just happened with T-Mobile, right? T-Mobile is now getting sued for their big breach that happened. So, there's no discrimination on who these criminals are going after, but that's my point on this, right? This is not telehealth, and I wish they would stop calling it telehealth, because this is not telehealth. This is telefraud. This is marketing fraud. This is schemes and artifices that are being perpetrated against federal payer programs by these unscrupulous scumbags. Eric,
yeah, I mean, I've been saying all along, I think it's a misnomer. It's telemarketing fraud, and one of the things that I say a lot. I do my retro fraud podcast with Advise, and I always say the circus doesn't change; it's just the clowns that change. Meaning that the fraud schemes don't ever change. And I talk a lot and I present a lot on telemedicine fraud and really these telemarketing schemes, because what they really are is, whether it's genetic testing, whether it is DME, whether it's the compound, whether it's topical non-narcotic mail order frauds, all of these schemes are reminiscent of the pump and dump schemes that were done in the 80s and early 90s involving the boiler rooms for stock transactions, right? So you've got these call centers with people where they're just calling a million times. I mean, how many of you have gotten a voicemail on your cell phone from Mary Fletcher, right? I just put up online the other day on LinkedIn, like I get about 5 or 6 of these recordings a day from Mary Fletcher from the Department of Finance or something, or my social security number being terminated or whatever. I mean, these are just, it's no different than the phishing schemes. And I worked a bunch of these compounding fraud, DME, genetic testing cases at the OIG in New Jersey. I would show up at people's houses and they would bring baskets full of prescriptions and just go, I thought my doctor coordinated with this guy, and what do I know? But yeah, calling it telemedicine is almost a disservice to telemedicine docs. And just to get back to your point about this, the usurping of an NPI and all of that, yeah, you just you use the term chow, which is the change of ownership, and in a recent retro podcast I did, I talked to one of my former coworkers about him working on cases where they were getting actual physical checks. The new fraud schemes now are that they're just doing EFT, electronic fund transfers, and that money is just being rerouted to bank accounts that are run by people that are intent on committing that fraud. But part of that is, and one of the things that I think we pride ourselves in on the advice side is that it's not just me, but there's a whole bunch of people that that I worked with who retired from the OIG that work with us. And one of the things I think that's helpful is we still have all of these really good contacts in the industry. So when people have these kind of problems, we can reach out to the local offices. We do a lot of outsourced SIU work. And so those connections on the Medicaid, Medicare side. But, to what you're saying, Sean, people need to be diligent. Like, you need to be diligent, particularly if it's an instance outside of the DME where it's referring. But if, all of a sudden you're seeing that there's an uptick in money coming in claims that are coming, through your practice, and you're not seeing that money, what's the deal here? I mean, like, where's this money going if you're not seeing it? People have got to bulletproof their practice. And I think, you use the term that's, we talked about this when we're talking about the OIG's 7 model compliance guidance. There's 7 points. And you really say there's an 8th point, which is really true, which is risk mitigation.
Right.
And this is really it. Like, how do you mitigate your risk? Because in the world of publicly available information, anybody who has an account with LexisNexis or Westlaw or any of those, you can go in and find an inordinate amount of information. And that's all publicly available information, property records. You see it all the time.
Yep. This is the last one that I want to point out, and I think this one gets the Chucklehead Award of the week, even above the genius who for $1,200. I think this one just takes the cake. And folks, I will post all of these noteworthy news clips for you to read a little bit later on today. But this one I think gets the Chucklehead of the Award a week. This is, and I never mentioned the organization's names because I just don't do that. But this is a medical supply company who on Thursday, July 8th of 2021, has agreed to pay $22 million to resolve criminal charges related to the fraudulent, you ready for this? The fraudulent misbranding of its micro-cool surgical gowns.
I like it.
How do you misbrand a micro-cool surgical gown? You know what? I don't even want an answer to that because we have so much more to talk about. Jordan, I want to kick it over to you, brother, because I know you had a couple of things that you wanted to talk about today, and I think Eric and I can opine on those. And then Eric, we want to get into the ECP discussion as well.
Yeah, no, absolutely. I mean, I think lots of changes. I feel like DC is lots of health policy, lots of focus. Obviously, price transparency has been on one of the major, probably in the top 3 that everybody's talking about. But CMS has kind of, they were really dug in. Xavier Becerra, his administration really dug in. Everything goes into effect January, obviously of this year. Then we're going to start sending out the letters. Then we're going to start sending out penalties. Well, now we're starting to see, some of that reel back in, which we knew would happen. But basically, CMS is going to delay that enforcement of the insurance price transparency rule by 6 months. Set to take effect January 1. Now it's going to be July 1. I guess the issue that I have is they state that basically the insurance companies, the hospitals need more time to post the machine readable file. Guys, it's a Microsoft Excel document. I don't really understand. It's very, very frustrating because we are making headway. A lot of the publications coming out, the relational data, where we can actually see it's not the end all be all. We know that, but some of the relationships we're being able to make are incredible. If you get a chance, Google Price Transparency Wall Street Journal or Price Transparency New York Times. These people are starting to pick this up. It will be the the mainstream media that picks all this up that's going to be kind of the catalyst of moving this forward. But it's like you can't talk out both sides of your mouth that we're committed to this. We're going to push forward. And then, hey, by the way, we met a little opposition, whether it be from the AHA, American Hospital Association, or more than likely some of the pharma companies. So we're going to back off a little bit. It's like, come on, guys. Like we know it's all happening. Let's push this thing forward.
Well, I think, and Eric, you'll probably agree with me because, you worked in government, and I've worked with, government for a huge portion of my career. I would not be surprised at all at the pushback from some of the people on Capitol Hill in the upper and lower chambers who are, as they say, being stooped with dollars from big pharma and from the hospital associations. And I'm sure there's going to be somebody out there from one of these groups that hears what I'm saying and they're going to try to blast me. But you know what? Those who blast away because they have something to hide. And let me tell you something. You don't automatically delay something that will ultimately benefit the consumer unless there's big bucks involved.
Yep. Yeah, it's going to be interesting to see who comes forward and how that rolls as far as how much money did it take or something like that. So it's going to be pretty interesting to see the fallout over the next few weeks of the replies to this.
Yeah. I'm going to stay away from the political stuff today, but for me, I went 2.5 weeks ago. I think I'm not sure if I told you guys, but I had to have an upper endoscopy, right? I have to have one of those every year for whatever reason. My GI doctor's like, nope, we got to do it every year. When I got to the hospital, this was the first time in 15 years of having these things done where when I checked in, they said, here's a price sheet. Here's a breakdown of everything that you're receiving today. And for an upper endoscopy that takes like 8 minutes to perform, maybe 10 minutes, it was $13,000 for me to have an upper endoscopy. That's what was built. I mean, it's literally a freaking garden hose with a light on the end of it. I know I'm making light, look, obviously, but it's an EGD. For $13,000, this isn't brain surgery. This is why our system's so broken, and this is why we need the price transparency. And to your point, Jordan, I think a lot of the insurance companies and a lot of the hospitals put a lot of pressure onto this administration and said, back off, okay? Back off, because, there are secret agreements that go on between these large hospitals and these insurance companies. There's all kinds of kickbacks, right, Eric? There has to be.
Well, there's, it just doesn't seem, I guess just from a consumerism perspective, why wouldn't you want to do this? I mean, you can, I think I've had this conversation with people where I say, in what other sector of consumerism in this country do you not know what something is going to cost you before you purchase it? Now, the closest thing I can come up with, I always used to say that the two things that would always give me the greatest amount of grief was purchasing a car and a mattress. Because when you go to buy a mattress, you go into your local, mattress store and you buy the blank Posturepedic 2. And then you go over to Macy's and it's the blank Posturepedic 5. And they're the same mattress, but because they've branded it for the store, you lay on one, you go, oh, this feels really good. You go to the other, go, man, that one feels better. They're the same freaking mattresses. And so, you don't really know what you're getting. But then with a car, even with things like Edmunds and Kelley Blue Book, there's all those buybacks. There's always, this rebate and that rebate. And so it really comes down to that when you leave the car dealership thinking you got a good deal, what you really should be thinking about is how much of a butt hurt did I get that I'm willing to take? Like, I know I got screwed, and I know that the car dealership made money. It's just how much money was I willing to let them make versus not let them make. But in no other sector of American consumerism that I can think of, do you ever go and get an item, a service, a procedure, anything, and not have some idea what it's going to cost before you actually get it done? I mean, where else does that occur with anything else other than American healthcare? And more importantly is that when you go and try to find out, like, well, what is this going to cost forget what I have to pay. What is this going to cost? Meaning, what is my insurance going to pay? What's my copay? What's my deduct? No one gives you an answer. How do you not know what the answer is beforehand?
And to Sean's point, that same endoscopy that he gets at the same hospital, they may his insurance $13,000. There may be another one that's $20,000. There may be another one that's $5,000. And then you go down the road, and it's like it's the same procedure done by the same staff with the same equipment with the same outcome. Nothing changes.
Well, how about the ones where the hospitals are owned by the same system? And two hospitals a few miles apart from each other, so they're part of the same hospital system, which means centralized billing, centralized operations, centralized purchasing, all of that, and it's two different prices to the same insurance plan.
Yeah.
And it's funny, we're in the middle of all this, and then we get this notification. This is 2 days ago, and this has made news, and it's been pretty interesting. And we'll let you guys carry on after this. But I don't know if y'all saw, like Cerner, obviously one of the largest EMR EHRs. We got Cerner, McKesson, Epic, all that. So they announced that their new CEO steps in, and his base salary is $900,000, a target bonus of $1.35 million, and he will be awarded $13.5 million with his Cerner's restricted shares in his first year. I mean, people are all over this because they're like, we're trying to go in this direction and this stuff happens, but now it's public, right? And so now people chastise. So it's going to be interesting to see the fallout from stuff like this. Listen, I'm not opposed to people making money, but given the current situation that we're in, what's going on, the preach of value-based care and quality, and then you have something like that. I mean, it's going to be interesting. We're going to start seeing more and more of this.
Yeah, $16 million to an EMR CEO, basically, while the rest of healthcare struggles to figure out where do we go. I mean, look what's going on. Again, the inpatient only list, right? 298 procedures are now being shifted back to the hospital, it looks like.
Yep.
I mean, any change on that? Have we seen or heard of anything that's going on there other than they're proposing? And I want to make this clear. They are proposing to take all of those procedures that they said were safe enough just a year ago to be done in the outpatient hospital setting or in an ASC, to now saying, nope, we've changed our mind. We don't think they're safe, and we're going to push them all back into the hospital. 298 procedures. Here's my concern. In my town where I live in South Georgia, okay, our hospital is back to status red. All of the surgeons have been notified that there are no more elective surgeries that can be performed at the hospital if the patient is going to require anything more than 23 hours OBS. There's no beds. So now we take all of these procedures that, look, here's my frustration with this. And I know we have several physicians that are watching this podcast today because they tell me they watch on a weekly basis. You've got to be kidding me. A physician is the person who is most qualified to make that determination as to whether or not a patient is eligible to have, and when I say eligible, meaning health-wise, that they're safe enough, they're healthy enough to be able to have this procedure done in an outpatient hospital setting versus another patient who has underlying disease process who has to have it done inpatient. I don't need somebody with a Harvard MBA telling me, no, we think this needs to be done inpatient. This is going to lead to, I think we even talked about this, more unnecessary admissions back into the hospital. So now their numbers are going to spike, right? All of these admissions. I mean, this administration can't get out of its own way.
No, I mean, I think they're struggling. I think you can't just, the vendors, I always tell people this, and get vendors, listen up. If you're going to have to start taking some of the risk. It can't just be the facility and the providers. I mean, we've got a local hospital here, St. Dominic's, and it was in the news. You can Google it. St. Dominic sues patients. And I mean, this is just, it's again, bad timing. You don't want this. You want it, this is the one you want to keep under the rug, but they sued an astronomical number of patients over the past 3 years through the pandemic. Then of those patients they sued, a large percentage of them were their own employees for medical. And it just came out, like it broke 2 days ago. So if you look at St. Dominic sues patients, it was their employees, dude. So now it's literally an uproar over here right now. And I'm like, golly, is this where we're at right now? But
who made that decision? I'd love to be able to sit down with the person and go, just, hey, let me ask you this, just between us. Bro, what were you thinking? I mean, that should be a segment. We should have a segment and just call it, Bro, what were you thinking?
I mean, I think I changed my mind on the Chucklehead Award of the Week. I think it goes to St. Dominic's in Mississippi, to whoever that Chucklehead was that made the decision to sue their own employees over medical bills.
I want to ask the CFO, CEO of St. Dominic's, Bro, what were you thinking? And I want to then go to the pharmacist for $1,200 and say, Bro, what were you thinking?
Look, if anybody listening out there has access to these Chuckleheads and you want to ping us and let us know who they are, I will reach out. Eric will reach out. Jordan will reach out, and we'll see if we could get them on. And maybe we'll do a new segment at some point down the road called the Chucklehead Award of the Week, and we'll have different people on, and we'll award them with the Chucklehead Award of the Week. But anyways, let's get more serious here for just a minute. Eric, let's shift gears and let's talk about ECP, okay? Because I know there's some things that are really climbing up your backside here that you want to talk about, and I think we need to really put these out there for our listeners because I think some of these things are happening where they're not even aware of it. So let me turn it over to you.
Yeah, I think that's true. So there's a service called EECP, Enhanced External Counter Pulsation. There's a HCPCS code. It's G0166. It's paid by CMS. A lot of commercial payers use that HCPCS code. There's also a corresponding CPT code, which I don't remember off the top of my head, but there's a corresponding CPT code. And it's really designed for patients who can benefit from getting this service, who have a type of angina that's not that doesn't make them a surgical candidate for one reason or another. And the normal prescribed course of treatment, it's 35 treatments at either 1 to 2 times a day, but each treatment is 1 hour. So patients can go once a day for 35 treatments, or they could stay for 2 hours. And essentially the device, it's this very loud, clunky device. You sit on a table, your legs go into these big sleeves, and the object is that it's compressing your legs to create a better flow of blood that's during your systolic and your diastolic blood pressures. And I just read an article recently that actually shows like that there is some efficacy to it. But in talking to some cardiologists, I think some will say that they don't think it works. Others will say it do. But that's either here or there. But I first got exposed to it in 2003 on a case that I worked in New Jersey involving a podiatrist who was using this. He called it the circulator boot, and he was touting it as a way for patients to come in and get physically fit without having to go to the gym. And he called it like a membership, and people were going and they were getting the boot, and there were a lot of things that happened, and it's a very crazy case, and I could spend hours talking about it. He ultimately pleaded guilty, but I've worked as an agent. I worked like 3 or 4 of these cases involving like fraud on them because patients are coming in. They may not qualify for the ECP because they don't have the clinical conditions for it. But the biggest issue is it's an incident to service, and you've got I had one case with a guy who was an internal medicine guy. He had 5 or 6 offices around New Jersey. He was running those boots 8 hours a day, 6 days a week. Patients were coming in and getting it, and they weren't even getting an hour's worth of treatment. So, even people that might have qualified for it were only getting 30, 20 minutes because he needed to churn the tables because these are expensive machines and you can only have a limited number of space and whatever. And so he put people on it for 20 or 30 minutes. And the sad part is people actually felt like they were getting some sort of medically efficacious service when they were really getting nothing. And there was just one recently. So, if you Google EECP fraud, you'll see there's a whole bunch of cases. I worked on one. I wasn't the primary agent. I worked on one involving a doctor by the name of Jose Katz. It was a $20 million fraud in New Jersey. I worked on a couple of others. Like I said, the one involving this internal medicine doctor who was using it, this podiatrist. You're seeing this starting to come up again. There was just that one recently in California. So you're starting to see this come up again. And again, I still think like putting this into that retro fraud perspective, that things come around, they then become dormant, they then come up again. The sad part is that from a patient perspective, patients sometimes will go to their doctor with a level of desperation, that my surgeon is telling me I can't get this surgery. I have unstable angina, but I'm not a surgical candidate. What can I do? And they go, oh, we have this great thing and it's going to help you. But if you're not going to give it to the patient under the prescribed FDA approval, it's problematic. The easiest thing on some of these cases I've worked, and even in my consulting world, we've done some work on these where the boot there's a report that's generated and it's got on and off times. And so you just have to look at the report and go, well, the person got on, the boot was started at 10 a.m. and the boot was turned off at 10:20. Like they're not even getting the hour that they need to be able to get this level of service. And so, you can go back to these providers and be like, look, this is the problem here. And I think it extends beyond just a fraud. To me, a fraud is I'm going to bill for a service that I didn't do. But when you've got a potential patient where there's an actual necessity for the service, but you're providing this substandard level of care, you're actually it's a twofold problem, right? So you've committed a fraud on whatever the insurer is, but you've really done a disservice to a patient who may be someone who could have benefited from that item, that service, that procedure. And to say, well, we did it, but we didn't really do it, becomes really where the problem lies.
Right. So I know you gave us a list of, I think about a half a dozen that could potentially fall into this category, right?
Yeah. Yeah. When we're talking about data, the thing that's always amazed me is what are the things that are out there from a data perspective, and why aren't edits being put in place to be more robust? And sometimes you get an answer, sometimes you don't. But, the ones that always amazed me were the cases that we would see at the OIG where the patient was the Medicare program was built for a pregnancy test for an 80-year-old Medicare beneficiary in a nursing home. Like, why is that even being paid? Or the pregnancy test on a patient who's a male. And we're not talking about a transgender. We're talking about someone who, the program sees that they're a male. And even if they're transgender, if it's a male living as a female, there's a pregnancy test can't be going on. And so, you look at some of these that stand out. Like, why is it that someone who is who's had a documented hysterectomy, and there's clearly been a claim with a diagnosis with a hysterectomy, and then a year later there's a pregnancy test being done on them? Like, why is that? I'm always perplexed from a data perspective. Why is it that something like that passes muster, and how is it that something like that gets paid is just something that amazes me.
Yeah, Jordan, I mean, you're our data guru. I mean, what's going on, man? What's the deal?
I mean, it seems that to Eric's point, it seems simple. These should be simple flags. I mean, if we're paying these EHR and EMRs $23 million a year, you think they could put a red flag in there to say, hey, Miss Jones is 92 years old. You ordered a pregnancy test. Do you think this would be a red flag? I mean, it seems pretty simple to me. Like, we could do this on a basic Excel spreadsheet. But no, I think this is it. We talk about fraud, waste, and abuse. And oftentimes, to Eric's point, this stuff does get caught on the back end. But really, why can't we do it on the front end and find this stuff on the front end? Because the amount of resources that get tied up on the back end, when literally, I mean, we have drug interaction rules, right? So for pharmacy, you can't take this drug and this drug. It throws a red flag if two drugs pop up, right? It's the exact same concept.
Right. It reminds me though, when so for a good portion of the early part of my career, I taught Medicare rules and regulations. That was a course that I taught almost on a daily basis around the country. And one of the things that we would talk about are the Medicare prepayment screens, right? So as you were talking about that, it reminded me of like procedure to procedure, procedure to sex, uh, frequency of procedure, you know, and I'm guessing, what I used to hear, back in the mid 90s was, there's so many procedures, Sean, how do you catch them all? Well, you use common sense. To your point, Eric, I mean, irrespective if somebody's living as a transgender, they were born a male but they identified as a female, and somebody's submitting a pregnancy test, that's just physiologically impossible, improbable. I mean, these are the things, and I think, to your point, Eric, we also live in a different day and age today where we have, a much more open environment, much more open community. Things are expressed differently, whatever it is. But we should be able to look at those, especially tied to the day and age that we're now living in, and say, okay, what edits make the most sense to be able to say this is just clinically impossible or improbable.
Right.
I don't understand why, and to your point, Jordan, I work with some great people over at Epic, and Epic does create a lot of their flags, but it's not Epic who creates them. Now they have their standard sets, but they leave those bundled edits or those different types of pairing edits to the discretion of the practice. But have you ever gone in to try to create an edit into one of these systems?
Oh yeah, then it's you need a degree just to do it, and I think purposely, right? Been made that way. I mean,
Yeah.
it's not that complicated. Literally, it's if then, it's a match lookup. It's something simple in Excel. It ought to programmatically be able to shift. I think some of it's created that way.
Yeah, there's no doubt. There's no doubt. It's all about revenue generation, no doubt, to be able to pay those $20 million salaries.
Well,
But
Sean, how does, I guess while, we're talking this is how does something like, the NCCI edits and the medically unlikely edits, is it just that, and maybe I'm just naive in this, but is it that an 80-year-old female getting a pregnancy test where the payer, whomever that payer may be, has the patient's date of birth, the patient's sex, knows that this is an 80-year-old female? How is it that something like that is not part of either the NCCI or, more importantly, medically unlikely?
Yeah,
yeah,
exactly.
I think it would fit better under the MUE
MUE.
under the MUEs, because for the NCCI edits, those are traditionally tied to bundling. So
Right.
if you have column 1 versus column 2, and you build this with this, this is considered a component of a greater or larger overall service. So
Right.
I mean, if NCCI wants to expand into other areas to where you could have these, but I think the majority of these are left to the discretion of the payers themselves under the MUE edits.
Yeah, but then you get into, okay, so a lot of these are going to pass muster. Then you have to get into your fraud prevention systems, right? And the analytic tools that payers are using that should be out there to stop some of these things. And it's not surprise. Look, things are going to pass muster, and I have this conversation with people all the time. Is that the mere fact that something passes an algorithm or an edit that's in place is not going to say that it's not fraud. I mean, people find ways to circumvent edits all the time. Modifier 25 is an easy example of that, right?
Right.
Throwing on a modifier circumvents an edit for things like E&Ms. And so when you get something that may pass muster from an editing perspective, it doesn't necessarily mean that it's not fraud. So someone could say, well, geez, they paid me for this, right? And so it must be okay. And it's like, okay, but it still gets back. The onus at some point still might have to be on the plan. Like, the example I gave you a little while ago before we went on was the person who is credentialed with a payer as a pediatrician, and they only have a pediatric population, and you see that. If you're seeing a 3-year-old patient and the patient is 3 years old, why would you be doing a pregnancy test? Like, there should be something that says that, that if then, that Jordan was talking about is really what it is. If the patient is 3 and you're a pediatrician, so that makes sense. Why are you billing for, why should the CPT code for a pregnancy test be going to a 3-year-old, in which there is, it is impossible that a 3-year-old could be pregnant.
Right. So that's your ifs and your ands that you would use in creating an edit in the system. And I agree with you. I think it needs to fall on to the payers. I think the payers need to do a better job at catching these, because again, at the end of the day, we work in a pay and chase environment. I mean, that's what medical insurance is, right? It's all pay and chase. To your point, Eric, that you made at the very beginning, this is the only industry that I can think of where services are rendered, you bill them to a payer, you have no clue as to what you're actually going to get paid, and then you get paid something without ever having to demonstrate you actually perform the service.
Right.
I for me, in my closing remarks, what I would say, I think people need to get back to the basics. Yep. I think all of those people that have been doing this for 10, 15, 20, 25 years, 30 years, I think you need to get back to the basics. I think you really need to go back to your refresher books. You need to go back to when you first came into the industry and you were learning about modifier 25, modifier 22, modifier 26, the TC modifier 59, 51, 58, 78, 79, 80, 81. Get refreshed on these modifiers. There's a whole slew of modifiers that have been added to the books. Understand the level 2 modifiers as well, your HCPCS level 2 modifiers. But beyond that, I think you need to go back and you need to start getting back into understanding the lay descriptions of these procedures. I think you need to reach out to your EMR vendors and you need to say to them, hey, listen, we're having a lot of problems with our claims. And for me, one of the things that I institute with all of my clients, whether I'm doing, third-party compliance officer services, or I'm doing, an overall audit, a revenue cycle audit of the organization, I tell them, you need to be tracking your claims that are being paid. You need to track your claims that are being denied, and you need to be sitting down with your staff on a weekly or at a minimum a monthly basis to go through all of your denials to understand why you're being denied. Because if you continue to submit claims for which you're being denied, you run the risk of abusing the system.
Right. I call that revenue. I call it revenue preservation and revenue generation. Yeah. And what I say is, look, I take the OIG practices. When we would run data, you're looking at a bunch of things. You're looking at yearly trends for a provider. You're looking at quarterly trends. And then sometimes you're looking at your top billing codes. And I say all the time to our clients, I say, what are you doing with respect to your trend analysis? Because the OIG does trend analysis reporting for outliers on fraud cases. Why wouldn't you as a provider do your own internal trend analysis? So, the example I always give is you're a general ophthalmologist. And so all of a sudden you bring in a retinal specialist. Well, now you're going to have a spike in a certain set of CPT and HCPCS codes that you didn't have before. And now you're an outlier. And so that's the time to start doing your proactive audits to make sure that your documentation is up to snuff, because you're probably going to show up as an outlier on that bell curve. And someone is going to flag that, whether it be the UPIC, a commercial payer, something like that. It's not to say anything you're doing is wrong. Maybe you've brought in a new piece of equipment. Maybe there's a new technology. You've got a new provider. Maybe you've gone from being an internal medicine practice to a multidisciplinary practice because you've brought in a neurologist and a cardiologist. Well, guess what? You should be changing your group practice from internal medicine to multidisciplinary, because if you're an internal medicine practice and you're billing out under your group internal medicine practice NPI all of these neuro tests, you're going to get flagged for that. Because they're saying, hey, you're billing for something that's not within your normal scope of practice. So, it's that revenue cycle is revenue preservation, revenue generation. It's like, and again, it's getting in front of these things, stay in the driver's seat while you can, because once the OIG has gotten their teeth into things, or the government has gotten their teeth, and you're no longer in the driver's seat. Now you're trying to figure out how to navigate from sitting in the passenger seat. You can't steer the wheel the same way.
That's right. And Jordan, in the closing seconds that we have here with our folks, I mean, again, it's all data driven. It doesn't matter whether you live in rural Mississippi, downtown Atlanta, New York City, Newark, New Jersey, or rural, Georgia.
I mean, that's what we're seeing in all this, guys. The data is 100% there. What we choose to do with it, you're going to start seeing it. It's going to start influencing your operations. You can't hide from it. I mean, we can go over this 100 different ways, and it's going to happen. If you choose not to engage it or get ahead of the curve, then you'll fall victim to falling behind. But absolutely, it will happen.
Yep. All right. Jordan, you got the last word in on today's podcast. Congratulations. I know that's always a tough thing to do with Eric and myself.
Y'all are good, man. It's a good time.
I will tell you this. I don't know about you guys, but at 48 years old and getting back into the gym and working out, when you were talking about that exercising without actually having to go to a gym, that was sounding really good to me, because everything on my body, my mind keeps telling me, yes, you can. And my body keeps saying, no, you can't, buddy. Put it down, walk away, go home, get that ice cream out of the freezer, pick up a spoon, and go watch some ESPN. But here we go, folks. This brings us to the end of episode 9 of Coffee, Compliance, and Chuckleheads. I want to say thank you on behalf of Jordan Johnson and Eric Rubenstein. I am Sean Weiss. We will be back next week with another live episode. We will try to do better, but in the meantime, be good to yourself, but more importantly, be good to each other. Take care for now.